session is about to start. And my name is Dr. Yao Adusipoku, a consultant public health physician with extensive background in tuberculosis. Ladies and gentlemen, the theme for this workshop is the use of point-of-care urine (LAM) as an additional test for diagnosis of tuberculosis in people with advanced HIV infection. There will be one main speaker. After the speaker, it will be followed by a practical session and then discussion time. Before I proceed further, the rules, the usual rules. Please write down all questions and let it be as concise as possible. Questions will be asked only during the discussion time. You can catch the speakers after the session if you have comments, please. And I want to state that on the size of the table, we have arranged, because of the practical session we're going to have, it's going to be very interesting. We have arranged some dummy urine, underline dummy urine, on the sides. So just be mindful of them. You all participate in this. So there will be a breakout practical session as I've indicated. What I want to do now first is to introduce the presenter, the main presenter. First, the main presenter is Professor Peter Puplampu, infectious disease consultant, University of Ghana Medical School and Korle Teaching Hospital. And then it will be followed by the practical session by Dr. Senyo Fumador, senior resident in infectious disease, Korle Teaching Hospital. And then during the breakout session, we will have facilitation by the LAM team. This includes Professor Margaret Latti, infectious disease and dermatology consultant. Please come forward, please. I would like you to sit in front here for me. And then Professor Stephanie Birium, infectious disease consultant, Copenhagen University Hospital, University of Copenhagen, Denmark. Dr. Vincent Ganu, public health physician, Korle Teaching Hospital. Dr. Felix Kojo Bisasovo, lab manager, National Tuberculosis Control Program. Ladies and gentlemen, time to call on Professor Peter Puplampu. Let's welcome him.
Thank you very much, Dr. Poku, Eduse, and we are well padded by very competent researchers and clinicians here, so we are not worried at all. Just put down your questions as we go along, and would be done in a few minutes. So this is how our presentation is going to go. We're going to have first a talk on the TB LAM, and then we'll move on to the practical session. So when you look at your tables, you see that some tissues have been distributed all over. There'll be a practical session just after that. Then we'll have the discussions. All right? Right, so TB. In fact, to just say something very short, it is an infection that is very difficult to diagnose. Something that when we were in doing residency, you could do all the available tests and still get negative. Patient passes on only for you to have a knock on your door by the pathologist that, look, you are not doing well and that your patient died from tuberculosis. And you are wondering, I did everything and yet did not get any positive result. And yet it is still TB. And so anytime there's a new diagnostic technique on the board, the clinician wants to make sure that he's aware of it and can use it. And in that light, we are here to also get to know a bit about the use of the LAM to pick up tuberculosis in hospitalized patients. So I hope that wherever you are, you will be interested so you can help your patients with that. All right, so I think we've gone through this steps. We just want to move on to take the overview. So one may ask, what is LAM? Okay, so it is an antigen in the bacterial wall, a glycolipid, the lipoarabinomannan. It's a glycolipid in the bacterial wall of the mycobacterium. And what happens is that when an individual has the active infection and the organism dies, the bacteria dies, the wall breaks down, and this antigen or the glycolipid is released. And that is what seeps out into the blood and then excreted in the urine. So that is the basis of the test. And it's also a test that has been well researched into and recommended by WHO to be used for patients that are severely immunosuppressed and on admission in various wards. Right. What is the evidence for its implementation? Why does it work best in patients with advanced disease or severely immunosuppressed? And when we talk about severely immunosuppressed, we're talking, if you want some figures, if the patient has a CD4 count below 200, he's deemed to be severely ill. And in such patients, you have, if that patient has co-infection with TB, then you're likely going to have a disseminated TB, something that is almost in every organ. And with that, the amount of breakdown of the walls that increases, leading to more of these antigens being released into the blood and the urine. And so in such patients, it becomes much easier to have the test being positive if you take their urine. In this same severely immunosuppressed patient, you are very much unlikely to get even sputum from them. When you look at their chest x-rays, they just look normal. And so you are unlikely to have sputum positive tests in these people. And so LAM then comes to improve so much on your ability to pick up this antigen, and its sensitivity goes up in such patients all the way up to about 70%. So that becomes a handy tool. These are some of the things that we're going to demonstrate to you, but this is just to show you the strip where the sample part is and where the patient and control bands would, and then also a picture of how a positive and a negative sample looks like, but you have a practical section. Now, what is the diagnostic performance of this test? When you look on the screen, you can see that with respect to sensitivity, the TB LAM in the patients that we've described setting gives you about 52% sensitivity in inpatients and about 29% in outpatients. For specificity, inpatient settings moves up to about 87%, and the outpatient settings about 96%. Does it reduce mortality? Yes, it's been found so useful that it reduces mortality. And the time round in testing is just under 25 minutes. And that is why it is so much recommended by WHO to be used. However, it is not to be used as a standalone. Just like as I mentioned earlier on, in diagnosing tuberculosis, you need to harness and use as many of the tools as possible so you can increase your chances of getting the diagnosis right. Now, important studies that have proven this. One landmark one is the STAMP trial, where similar techniques have been used. Patients on admission have been tested, the urine have been taken, and the LAM tests have been done on them. In Malawi and in South Africa, these have been done. And the TB diagnosis has shot up to about 7% in this group of patients. And so that affords a quick intervention to decrease mortality and ensure that patients are treated much earlier. And the clinical baselines that were found in these patients, or that qualified them to be recruited, included you having a baseline CD4 count of less than 100, being anemic, and having a clinical TB. And so this fits so much in the case scenario that you would always have when you have a patient with a co-infection and severely ill in the ward. Meta-analysis also of various works that have been done, when pulled, gives you a sensitivity in the persons living with HIV up to about 42%, and for specificity, 91%, with strongest benefit in hospitalized patients, patients with advanced HIV, and those who are unable to produce sputum. So these are studies that support the use of this urine test. WHO came up with a guideline that these tests should be combined with the automated nucleic acid amplification test. And the rationale behind it is to ensure that no patient is left behind, whether you are severely immunocompromised or not. Because if these two tests are combined, whether you are in the hospital or not in the hospital, the likelihood of you being picked is so high. So the recommendation is to use both the nucleic acid testing and then also with the urine. And the reasoning behind it has to do with the fact that in the first one, picking up the DNA of the organism using the nucleic acid, the low complexity automated nucleic acid amplification test. And so with such, persons who have pulmonary tuberculosis gain the upper hand because these patients can produce sputum, and the load in the sputum is so high that you can pick them up. In addition, when you add the urine, which would go for persons who cannot produce sputum and are so ill in the hospital, when you use the LAM, you pick a high percentage. So if you combine the two, you are likely to have an increased diagnostic yield. The chances that you're going to miss out cases are very low. And then you can have the benefit of treating your patient very early. And that is the basis or rationale behind the WHO guideline of not using either one of them alone, but doing both tests to pick up the diagnosis. Right. And so this chart is just to show you the various advantages that you get. In the case of the nucleic acid amplification test, you are sure to have them best for patients in TB, pulmonary tuberculosis, whereas the other one for disseminated tuberculosis. And then with a high specificity in these people with the pulmonary. And then when we come to the LAM, you are sure to get it because patient can certainly produce urine whilst on the ward. So you are unlikely to miss out on that. Of course, each have its limitation. Once you know when to use each of them, you are at a bigger advantage. All right, so that is what is stated there. Concurrent use is what is being advocated for. Right, so way forward. With these tools at our disposal, it is something that we need to drum home about, and we really thank ICASA for giving us the platform to be able to showcase and make the information go out to areas that are high burden, and to ensure that in the real world, these things are being done. It is not a fluke, it has scientific background, and we need now to drum in the story so that it is scaled up in all the regions or areas that have high burdens, and then be integrated into our TB HIV care cascade so that we are sure that it is being implemented. Then also the issue of monitoring the impact. Once it is being used, I'm sure other things will be added to ensure that we pick up information that will help us to be able to further inform ourselves of what we're doing. And so that's why we are here to talk about this study. So in summary, advanced HIV, as we all know, alters the presentation of tuberculosis in individuals, just like I mentioned from the beginning. And so to have this dual testing with the help of LAM getting us to detect the cases even in disseminated TB, it's a good news that we should all try and push so we don't miss any patient. Then also reminding ourselves that it should be done concurrently with the nucleic acid amplification test. Reminding ourselves also that the LAM is very quick, non-invasive, and you can use it right at the bedside, as we're going to demonstrate this afternoon. And the fact that the other test also gives us confirmation and helps us to be able to detect resistance with these tools. I hope that after this place, we'll all be ambassadors to carry the news to our various hospitals and clinics. Take home. LAM is a very useful adjunct diagnostic HIV positive in HIV positive patients, and especially those who are severely immunosuppressed, and should be used in our algorithms, and also implementation in various settings can help us to be able to detect TB very, very early. And it is important for various hospitals to ensure that training in its use is made accessible, and clinicians get to understand and use it so we can save our patient. I think this is about my last slide before I leave the stage. Thank you very much.
Thank you very much, Prof. Mr. Chair. So I would quickly be taking us through a practical session on how to apply urine LAM on our patients too as well. All right, so we'll go through a quick look at how the assay looks like, and then what the procedure would be like, and then how to effectively interpret the results. So this is how the test strips looks like. And currently, the only WHO-approved point-of-care testing for extrapulmonary TB with sensitivities and specificities as espoused by Prof. Puplampu. It's a simple instrument. It doesn't require any highfalutin procedure or anything. And in about 25 minutes, you have your results as well. And cost, about $3.50 per head. So it's something that we can easily implement in our facilities. So if we take the testing strip, this is how it actually looks like. It comes as a package, but you would have to take one strip off per patient. You would have a part that is closer to the blue portion where you'll be dropping the specimen. And in this case, the specimen is a urine sample that you'll be taking from a patient. And then after 25 minutes, you will do your readings in these windows. The closest window to the specimen portion is your patient window, this here. So you would, if positive, see a band, and then this is for quality control. So this will be your control window too as well, for which if a test is to be valid, there has to be an appearance of a band on this particular side. And may I say that this test is not used or interpreted alone, but there is a reference scale or a reference card for which whatever reading that you'll be using over here would have to use these various intensities of lines that you see here to determine whether there's a positive or, in the absence of a band, a negative one too as well. So, how does the procedure go? You tear off one strip from the full package, and as you'd be practicing and you have your facilitators help you, you would tear it from the top portion all the way down. And then you pick about 2 drops of urine and then place it at the sample site, right, which is closer to the blue line. And that's about 60 microliters of urine. And then you would wait 25 minutes. Please, not lesser than 25 minutes. All right, so how do we interpret this test? A test is said to be valid if you see your control line. So that's the first thing that you'll be looking out for, the appearance of your control line. Then you will look if there's a band on the patient sample site. You will then compare the intensity of that band to the reference card as was shown on the previous slide to determine whether you have a positive or a negative test. So this is an example that we can see. This is the test strip. The sample has been placed here. This is where we read the patient's results, and this makes the test valid or not. And then you use your reference scale or your reference card. It's very, very important. So you just don't get up and de novo read and look at it, but you need to compare it to the various grades of intensity of the bands that you see on the reference scale. So at this point, there's a very short video, but before we go to the video, I would want us to just break out to the nearest testing kit that is close to you. Find it just by the end of your aisles. So if you can just all just move hands on. There's more than enough for everybody to pass around. So just locate yourself, and then we will just play a short video. We have nothing to declare when it comes to this particular video too as well. So can we make ourselves to the edges of the tables? And then we have our facilitators who would come in. I can see some people already gloving. All right, so on every table, you have a dummy urine sample. You have a pipette to pick your urine. You would have your testing strips, a pair of gloves, and then a reading card. So when you get to your station, just make sure you have these things available. We have our facilitators also to take you through too as well. So does everybody, okay, I can see everyone. So we can just watch the video, and after that, enjoy your... So can the IT team please help us by playing the video from your end? Okay, so whilst we are still sorting out the technicalities, can the facilitators just get down and then explain the procedure as it is? So you have your test strip, you locate the portion which you have to tear it off, all right? So this is, you are taking a trip down memory lane, our chemistry practicals as well. So have you all identified your urine samples? It should be quite looking like a urine sample, all right? It's in a container. You've all identified your test strips. They come with a metallic foil that is over it. Have you all gotten there? Yes? Great. All right. So we have our pipettes. Okay, yes. Mr. Chairman himself is our chief chemist. All right. So we have our pipettes. All right. And then you have your gloves and then your reference scale. So what you need to do now is just to tear off the aluminum foil. Oh, I can see some people are already way ahead of the group. All right. Some have already drawn out their urine samples. Please place 2 drops into the sample site. All right. Just 2 drops of that into the sample site as well. And then, well, we'll hypothetically wait for 25 minutes to see. However, you will notice that there have been some pre-made test strips that have been attached to your kit. So when you finish your testing, kindly use the pre-made kits and let us know whether you have a positive sample or you have a negative sample or you probably have an invalid sample too as well, and tell us the reasons why. So our facilitators will be there to help you through. If you need any help, please just raise your hands. Okay. All right. Great. Yes, you take it off. So please do take off the aluminum foil. So yes, you take it off. Excellent. All right. Yep. Great. So where are we going to put the sample? So have a look at it again. All right. Oopsie, bro. So let's all give it a try. Let's take a trip down memory lane. Some people's hands are shaking, so just 2 drops. So when your hands is over shaking, drop one, take in a breather, and drop another one. Or some people are flooding the samples. All right. So let's see how many of us were good in chemistry practicals. If you need any help, just raise your hand. Facilitators are available to take you through. So yeah, we have some pretty good Einsteins and chemists amongst us. Now to see whether they have 25 minutes to spare, which we probably don't. So at least I hope everybody has gotten a hang of it as well. It's just a lateral flow cassette type of testing that we normally do too as well. So key point is always use your reference card. All right. So you'll find attached to your testing kit samples of tested clients. So compare the intensity of the bands on the sample, on the pre-tested samples. This one. So this is your reference card, right? So you compare. Okay. All right. So please do compare. Test yourself. Are you having a valid reading or not? Are you having a valid? Wow, someone has to remove their glasses to see. I like the intensity. All right, that's great. So, what is your result? Would you want to comment? Would you want to comment on the result? So not now, because it's not yet 25 minutes, isn't it? So he's following the steps. However, there are other charts that you can use which have been provided to you. So you can use this one and compare it to these ones. All right. So you compare the intensity of these bands, all right, to this one. So when you see 2 bands, you assume it is positive, all right. When you see 1 band, it may be negative or it may be invalid, depending upon where the band is. So if you have a control band in place and the patient's band is missing, that is a negative result. Kindly compare to the tests that has been. Would you want to comment? Or later? You come. All right. So, would you want to comment on the testing strips? To see what they are seeing. All right. So I think that what you should wrap up. Has everybody finished? Then you focus on this one. Okay. So we'll move to the discussion. All right. So have we all gotten a hang of it now? Have you all had a try at it? Okay. So I would hand over to the chairperson to continue. Oh, okay. So I would quickly once again go through the interpretation. All right. So I would go over this point again just briefly and then we hand over. So to have a positive or a positive test, there should be a band at the control region. Control region, there should be a band. And then there should be another band at the patient's region too as well. So if you see only the control and you do not see another band at where the patient's band is supposed to be, that would be a negative test. So 2 lines, one at the control, one at the patient's region is positive. 1 line only at the control is negative. If, no matter how many bands that you see, if there is no band at the control region, it is an invalid test. This is very important. No matter how many bands that you see anywhere else, if there is no band at the control region, it is a negative test as well. So I hope everybody has gotten that, Mr. Chair.
Thank you. What can we say to them? Thank you. Shall we give in to them, please? Thank you so much. It's questions time. And I'm sure we have some questions. We'll start from the far end. We'll move from there and then across. So you mentioned your name and your institution, please. Can we get the mics to them, please? Yeah, so we're starting from there.
Yeah, my hands are dirty. Yeah, thank you very much for that presentation. In terms of heat stability, I just wanted to know, okay.
May I know your name
right,
and your institution?
My name is Dr. Evezio Pokoro. I work with the Institute of Human Virology Nigeria, IHVN for short. I just wanted to know about the heat stability of the product. How stable is it? In what conditions should it be stored? Given the fact that we have very remote sites where we might need to store this in some, we might store it without any conditions. I just want to get a sense of what's the storage requirement for this kit.
Thank you. So, can we have another one? Yes, please. Over there.
Thank you so much. My name is Dr. Chris Abana from Noguchi. I wanted to find out, how many pilot studies have you done so far? And is it currently used in the country? Or just, is it something that you plan to roll out in the whole country? Right, thank you.
Thank you. We come to, yes, please.
So my name is Dr. Elizabeth Ejare from the National AIDS and STI Control Program in Ghana. I was looking at the test kits and I find it very difficult to use, not because the drops are difficult, but you cannot read the patients and the control side. So is there something that can be done by the manufacturer to make it a bit more visible? Thank you.
let's maybe we can have one more. So okay. So can I call all the facilitators and the presenters here, please? Very, very important. There's a question here. Okay. You kindly add yours. Maybe there are some online questions. IT, are there some online questions? No. Okay, please alert us. Okay, so where's Professor Margaret Latte? Dr. Kojo Sovo is here? Yes. Okay.
So, just a final question.
Yeah, please go on.
I just want to know.
Thank you very much. I'm Dr. Mfundi Mota from the Kingdom of Eswatini. So I'd like to know two things. With the specificity at 60%, rather the sensitivity is 60%, and on the results you presented, I think it was around about 30-something%. What effect could it have in terms of correctly diagnosing the disease with that very low sensitivity?
Okay. So
then the next question is on the practical section. It seems as 5 minutes elapse, some of the strips, they don't show either the control nor the observance patient. So could it be that the test is expired?
Let's hold on here. We will answer and we'll come back to the second round of questions. So let's begin from the last question. Okay.
All right. So since I facilitated the testing, I'll take the last set of questions.
And then also add on the WHO program of sorry. Yes. So she asked the question, was difficult to use the strips. I think they go together.
So actually, the testing kits that you are using are just dummy testing kits. They are expired. The samples that you are using are not urine samples. It's actually apple juice. So, cheers. All right. So, in terms of the writings and then the labelings are a little bit small for some people. And in some of the pilot studies, at least one that I'm familiar with, one of the complaints or the feedback that we got from the nurses and the healthcare practitioners that unfortunately the PI of that project could not be with us, Dr. Joanna Beck. All right, so in that study, one of the feedbacks that she got was the same thing that you had actually espoused. So I think that will go back to the manufacturers and then WHO to make a decision on that too as well. I'll let my colleagues also add to it.
Yeah, thank you. And I might just add to that there have been some trials where they tried to do a little tool that reads the test automatically. So either with AI or with something, so we add that so that it comes out like grade 1 or 2 or 3 or 4 or negative, which would be more simpler and also take away the subjectivity and depending on the light you are reading it in. But I think in general it's relatively easy, as you have seen, and like a pregnancy test type of thing. But you're right that there are something there that could be improved, and I don't know if it's the manufacturers, I not necessarily, but others are actually working on it.
Thank you very much, Dr. Jari, for the observation. So you'd realize we provided you dummy samples and then also kits which have already provided results. Are those ones readable? Okay, so I asked because for most of these test kits, it comes with a packaging insert. And the insert tells you what to look out for, as in the results that would come up. And so if you look at the other two strips which were given, the bands are quite easy to read from those sides. So that's where the packaging insert comes in. Because before you use the kit, you would have gone through the packaging insert to know where the control bands are and where the patient results are before you do the test. But like Prof rightly said, these are feedback which are meant to improve on the test. So, Prof, I'm sure you would get back to the manufacturers.
Prof
Right.
Latte is here.
Yeah.
Yeah.
So thank you very much. I had a comment from a colleague here. He says by 5 minutes it should be showing the positivity. Please no. The manufacturer's recommendation is 25 minutes. So don't assume that by 5-10 minutes you should be seeing something. It's 25 minutes. So if you are seeing anything by 5 minutes, you yourself, you should be thinking that, there's some invalidity there. And then again, as it was being presented, there's a place to put the patient sample. There's a place to read the patient's results and a place to read the control results. You need to know that so that you don't confuse the two. And of course, if your control doesn't come up, then the test is what? Invalid. So one must come before the other. You must read the control first before you read your patient's result.
Thank you very much. There are two more questions to answer. One from the Nigerian. Yes. And then, has it been rolled out from Noguchi? So, can Dr. Sovo answer the one? Has it been rolled out?
Okay,
This
so,
is at the programmatic level. Yes.
so what is happening this afternoon actually are part of the processes towards rolling it out. But we want to sensitize the public and let them understand that these test kits are also available. Between the National HIV AIDS Control Program and then the Tuberculosis Control Program, there are already plans to procure these strips and then to use them alongside what is being done at the CD4 sites. Like the presenter rightly said, you would normally make use of them in situations where you have advanced HIV disease. So for those patients, the thinking is to ensure that once you've done the CD4 count and the count is low, you would also do a TB-LAM test. So hopefully into 2026, it would become part of our algorithm going forward. Thank you.
So then we are saying the same thing to Nigeria, the Kingdom of Eswatini, wherever you are coming from. We need guidelines. Okay. We can afford one more question because time is fast spent. Yes, my dear.
Yes, thank you very much. I'm Dr. Elizabeth Kihika from Alive Medical Services in Uganda. Mine is not really a question. It's just sharing an experience. In Uganda, this was rolled out, and it's a standard that everyone who has a CD4 below 200 has to have both a TB-LAM as well as urine crack test. So, serum crack test. And it has really helped us catch that TB. Because most times it's difficult. They're either not coughing, but you see the person, there are signs and symptoms of TB, but you're not able to get the sample for sputum analysis, so it is actually disseminated. So it has really been quite useful in our country in catching that TB at that point in time. Thank you.
So, yeah.
Yeah, I've gotten a response to my question about heat stability of the product. But I wanted to add another question on it about, I know this is, as you said, apple juice. Does the urine get dried? Maybe if you put a drop or two before, for some reasons, it just dries. Are you allowed to top up if you've added 2 drops, or maybe you think it's not enough? For some reasons, you want to put more drops. Is that allowed, or strictly must be 2 drops? I know this is just practical, but just to get clarity on that.
Thank you so much. Shall we thank the presenters and the facilitators? Time is fast spent. Okay, we're supposed to close at 2:50. Yeah, it's 2:50. Okay, your comment.
Sorry. So you could add, it's between 2 and 3 drops. And so sometimes you'd realize that though you've added 2 drops, as the urine flows through, it doesn't get to the control section. So you might add 1 more or 2 just to make sure it runs to the end. These kits are extremely stable, and particularly even at room temperature. You don't need to keep them in a temperature, frozen or whatever. Room temperature is good enough, and it's quite easy to also transport to the community to use in the community. It's actually one of the most stable strips you can find for testing. Thank you.
Thank you very much. Thank you, thank you. Please, you can have your seats. Thank you. Thank you so much. Just to conclude, I have worked in remote areas. One of the difficulty is sending a mother and a child, referring right, taking transportation to the regional hospitals, to the teaching hospitals. It is difficult. This is a point of care test. Please, let's leverage on this. Let's expand our diagnostic network using what we already have, the DNA testing, and this other pathway. And it's all about the subserved, the marginalized. Thank you very much. Thank you. Bye-bye.